Well, I'll just want to get started by saying that we put this breakout on the agenda because we want to hear from you about what we need to be doing at NCCS to advocate for the needs of people with metastatic cancer. And we've always, our founders, many in 1986, when they started NCCS, always thought of the organization and survivorship being from diagnosis onward, regardless of stage of disease, and not a focus on post-treatment people who've rung the bell. So so that's always been part of who we are and what we believe in. And I just hear more and more just through Twitter chats, which sometimes I participate in, sometimes I just kind of monitor, here. And if you joined us yesterday, you heard Dr. Smith. I really wanted him to talk about his article that he wrote about to study metastatic survivorship. And in the article, he talked about the actual research that needs to be done, in addition to, what we're interested in too, is what services we need to be providing, or we need to be advocating for. But I hear so much about people being excluded from programs because they have advanced cancer as opposed to early stage cancer. And so I just wanted to hear from you all, and I asked Kelly to help us. And maybe Kelly, you can start by talking about what's important to you, and then maybe we can also kind of talk a little bit about some of the Twitter chat that's been going on the last couple of days. I know because there was a lot of discussion at the LBBC meeting for metastatic breast cancer over the weekend. So I'm going to turn it over to you to talk, but I just want to listen because what I really want is to inform what we advocate for and make sure what we're doing, what you all need us to be doing.
And I'm going to apologize in advance because I made the mistake of not putting my dog in the bedroom, and he's going to bark and I'm going to throw a pillow at him in a minute. When I was first diagnosed with metastatic disease, the word survivor was like nails on a chalkboard for me. It did not resonate. I am not going to survive this cancer. I'm going to die of or with metastatic breast cancer. And really actually felt alienated by the use of the word survivor and survivorship until I went to a retreat / conference where Shelley was. And Shelley talked to all of us about NCCS and NCCS's diagnosis of survivorship, which begins the minute you're diagnosed, and you're a survivor all the way until you die. And I was like, oh, okay. So I'm not going to jump down someone's throat if they call me a survivor, if I think of it in that sense. I still personally do not call myself a survivor. I say that I'm living with metastatic cancer. But it's not the same nails on chalkboard as it once was. But there was a Twitter discussion yesterday on the whole idea of survivorship programs, palliative care. Should palliative care be called supportive care? Study out of MD Anderson showed they had a much greater uptake in acceptance when they changed the name of their palliative care program to supportive care. And one of the things that still happens, and there's newer definitions with the Commission on Cancer about survivorship that includes that spectrum from diagnosis through death. But that's not trickling down into the real world. You may find people that at NCI designated comprehensive cancer centers who believe that. But one of my friends with metastatic disease, her hospital has a survivorship program. She has called about it and they're like, oh no, you're metastatic, you're in treatment. And our program is for when you're finished treatment. Well, those of us with metastatic disease are never finished. So, excuse me, that's really, still an issue of perception around the country. And I'd love to hear what some of you guys have to say about what your experience is with survivorship programs, or how the word survivor resonates with you.
All right. I was operated 6 years ago with stage 4 at Hopkins, vocal cord cancer. I have a guardian angel. I've been clean since my operation. I never liked the word survivor. I never used the word survivor. I don't know what tomorrow's going to be. We're all survivors. you drive your car, you go swimming. But I have two other issues. The first is, except that I have incredible doctors. My doctor from Hopkins now is at Harvard. My doctors down in University of Miami, they're incredible. They're there. But basically, I'm done. You shouldn't be done. Nobody really follows me. I'm very assertive. Not that I need to. I've been following this organization for years because I went out of my way to get information. I live with a different side of cancer survivorship. We're a very, I don't know what the word is, superficial world. I've had to deal, I've been blessed. My doctor gave me a tap. I've been talking since day one. I survived, I gained my weight back. I'm basically normal until I open up my mouth. Nobody accounts, and I'm very strong, so it's okay. But nobody accounts for the side effects of cancer. Side effects, you have a mole. Side effects, you have one breast. Side effects, maybe you lost a leg. There's a whole different part of cancer survivorship that people don't realize. All right, I'm done for now.
Thank you, Gina.
Thank you for sharing, Gina. Martha, Doug, Bethany, Louise, any of you have anything you'd like to add?
I definitely don't like the term survivor. I mean, I hear a lot of people on Twitter, pushing for it to be used, but I just can't relate. I don't take offense anymore, like you, Kelly. It doesn't resonate with me at all. In terms of programs, my hospital doesn't have, well, they're trying to resuscitate the palliative care program. But I've had numerous experiences where I've attended things locally, and once they realize my stage, they're like, maybe you shouldn't be in this program, which is, obviously tremendously hurtful, offensive, shows a lack of understanding of what life is like now at this stage. Yeah, that's my experience.
Yeah.
I would say, like, similarly, when I was first diagnosed, so I was misdiagnosed for 9 months. And I was diagnosed at the age of 30 with stage 4 neuroendocrine cancer in my pancreas and appendix. So I've had 2 surgeries and it spread to my liver. And so I have a kind of cancer like no one's heard of before, and it usually affects people in their 60s or 70s. So I have all kinds of like issues that I run into. Like I'm in a Facebook group with, most people are stage 4 when they're diagnosed because it's so often misdiagnosed. But I end up with people that are like, oh, you're stage 4, just go on disability. Like that's what I'm in a Facebook group for people with neuroendocrine, and people are like, oh, just retire. And I'm like, I'm 32. Like my career is just starting. I'm not planning on retiring or going on disability anytime soon. Like I am planning on living for another 30 years. I'm not working on end of life planning. I don't care if it's stage 4. And so I run into like, I don't fit in the neuroendocrine world. I don't necessarily fit in the metastatic cancer world, I feel like, because I'm no evidence of disease right now. So I'm not in active treatment, but I'm not like all clear. Like it's going to come back. It's just a matter of when. So I end up like in this, I feel like gap in multiple areas that I can't really find a place that I feel totally welcome, that I belong in. So just trying to figure out where that is. I hated the term survivor when I was first diagnosed because I was like, survivor means you're done and I'll never be done with cancer. I talked to my therapist about it, and she was of the mindset, she's also a cancer survivor, that when you're first diagnosed, you're surviving it. So now I don't mind the word because I'm of the same mindset. Like the minute you're diagnosed, you're surviving cancer.
Yeah, I think, I think that's so true. And, it's so hard. And, you have the young adult cancer thing. It can be a different space. Although there are some amazing people, Mark Lewis, the oncologist who has neuroendocrine cancer himself, is a pretty amazing person. One of the other things is this whole idea of survivorship. Many of us with metastatic disease are living heck a lot longer than anybody ever lived before. So nobody ever thought that they needed to worry about survivorship programs for us because, we were going to croak before any of these issues arose. And so one of the doctors yesterday on this Twitter conversation was like, well, palliative care. And I'm like, I have metastatic breast cancer. I really don't have pain. I don't have depression that I admit to, at least. I don't have all the things that palliative care usually takes care of. But as someone who had early stage breast cancer 12 years ago and has been metastatic for 6.5 years, and I'm not planning on being dead yet anytime soon, some of the long-term collateral damage from our treatments really make survivorship the place. The cardiac effects, the osteoporosis from, from treatments we've been on, and certainly the financial toxicity. And like you mentioned, Bethany, the whole idea of working and not working, and you're in your career. So survivorship programs, a lot of them seem to address that better, but a lot of them don't have that place for us. So I think there's a lot of improvement that can be made in the world of survivorship programs to help us all out. Have any of you guys been enrolled in a survivorship program at your facility?
I don't even know what
I didn't want to do it. I must be unusual. As soon as I talked and survived, I want to be normal. And I've been blessed to be able to go on. And when I go to laryngectomy groups, and I've tried them, they talk about how sick they are of this. I got up and did a 26-mile bike ride. Now, I'm not saying I'm perfect. I'm just saying I get depressed going and hearing about that I'm so sick, or I don't feel sick. I feel blessed. And I have one other thing to say, and please don't get mad. I don't have stage, I'm been blessed to be in this stage. But I don't think it matters if you have stage 1, stage 2, stage 3, or stage 4. You have cancer. I say the worst words that ever came to me were, you have cancer. And I think if you're in stage 2 or you're in stage 3, you're still thinking about how long am I going to live? Is it going to come back? I think there's a set of issues, things we go through when we're diagnosed, regardless of number. I'm sorry, that's just how I feel.
Thank you. I appreciate hearing your perspective on it. One thing that's funny, my mom had DCIS, so stage 0 cancer. And she doesn't like the term survivor either, because she doesn't feel like she qualifies, because she says I had baby cancer, and people who've had it so much harder, I don't feel like I deserve to use that word. She never has called herself that. I think, I think everybody should use the words that resonate with them. And I totally understand why it wouldn't resonate with people, with a lot of people, whether you have stage 4 cancer or you just don't like the concept of it. But I think your point, Gina, that, when you've heard those words, you have cancer, then you know, even though you may have a different experience from somebody else, you lived that kind of fear and terror really of that and how that affects your life. So thank you for sharing that.
Actually, Gina says something interesting. Do early stage people from the beginning call themselves survivors? I don't think so. I think it's when they're done with treatment.
I mean, some do, some don't. And it just depends on I think that a lot of times they don't feel like they can until they're done with treatment.
Okay.
I think if they've been, heard sort of the definitions that some people use, and then, oh, okay, well then maybe I guess I can call myself a survivor, but I don't think it's their instinct to call themselves a survivor yet. It's like, well, I'm still in treatment, so I don't qualify yet.
Okay.
I mean, I just think in our English definition of survivor, the way we use survive is you have come through something and you're on the other side. So, it's a word that's fraught for a lot of people, no matter what, what it is. I do feel that I survived my daughter's teenage years. We are past that now. So I can say that I survived female teenage parenthood. So, that we all use these words differently. We have had a couple people join us, and I just want to let you know that this is a very informal, interactive session. I might be sitting here with a blazer on, but believe me, I'm wearing leggings on the bottom, and Shelley said she has jeans on. So, we'd love to hear what you guys think, because I think part of this is, NCCS has done a lot of work for a lot of years in this space. And I think we all realize that there's room for improvement in survivorship programs and palliative care programs. And the best way to improve is to hear what the people who might use these programs or want to use these programs, but they're not available to them, what they want. I always say, hashtag nothing about us without us. And that's true when it comes to research, when it comes to survivorship, when it comes to what we call things, to calling people out on Twitter, at conferences, whatever, when they talk about diet, exercise, preventing cancer. That's a pet peeve of mine. The only thing that prevents cancer is to not be born. Words matter. It's risk reduction. So really would love to hear from you guys with either successes you've had or frustrations you've had, whether the term survivor resonates with you, whether it doesn't, and why.
I had one case. You talk about frustration. I won't name the group, but it's a cancer support group, a facility, and when I went, they said, we can either be in the living with cancer group or the post-treatment. And since at that time I was post-chemo, that's the group they wanted, but I said, I'm living with cancer. That's the group I should be in. Well, you've already had treatment. So it was kind of a survivor thing. Cause I don't like the word survivor either, because I was diagnosed de novo. So I only know stage 4, and pretty much I know every treatment that I've done and what I'm going to do. And when that last treatment fails, which they all eventually fail, then I'm done. So to me, I don't know how to use the word survivor, because I can see my whole path to the end, and there's no surviving. I guess I get up every day. That's surviving, but I don't know. I just don't like the term myself. But I understand some of y'all. I don't get frustrated. Like I'd be interested in what I think this Shelley or someone gave a talk about it. I don't know. At the retreat you were talking about, what changed your mind about that?
So this retreat is a program called Escape for Advocates, and it's any type of cancer. It's not just people who have been diagnosed with cancer, it's people that work in the cancer space. So I think I went in 2018, and there was Shelley was there as one of the presenters. There were people with all sorts of different types of cancer: lung, colon, melanoma, breast. And there were people that worked in the cancer space, like clinical, like social worker, oncology social worker, people that worked for foundations. There were some representatives of industry, because like everything else, this is partly sponsored by industry. And it's a combination of a retreat. It's held at the Miraval Spa in Arizona, and a learning opportunity and a introspective opportunity as well. So it's open to all people. The website is escape4advocates.org, I think. So, and again, I was early stage, finished treatment, thought about myself probably as a survivor for a couple of weeks until I was diagnosed with metastatic disease. And really would get kind of bitchy if people called me a survivor, until I listened to the presentation from Shelley, and God, there was someone else, and I don't recall who it was, who spoke about her experience with NCCS.
You know, Susie.
Susie,
Lay.
yes.
Yeah, she was one of our founders back in 1986.
And one of the slides Shelley put up was the definition that survivorship begins the minute you're diagnosed and continues throughout your treatments and post-treatments. And if you have a cancer that, is not in remission, that it continues up, up until your death. And I was like, okay, I may not call myself a survivor, but this is a definition that doesn't feel like it's excluding me and all the rest of us that don't have cancers that are one and done treated.
Mm-hmm. And Kelly, I like the way I've been trying to use, I noticed that you say that you're living with cancer and you don't call yourself a cancer patient. And I get that. And I like that a lot. And I've been trying to use that. I mean, sometimes it's hard because, I have to retrain myself because when I'm talking to people on Capitol Hill, we talk about cancer patients, but I'm really trying to use people living with cancer
right.
more than cancer patients because I think that is, does a better job of recognizing that you're human, not just a patient, but also the living with part. Yeah. And that living with could be, months for some people or many, many years. And I think, that's, what you said before about how people are living with advanced cancer much longer. And that's why I think, I think the medical community is still trying to figure out what to do with that, and again, they still focus on the medical side of it and not all the other pieces of life that may need help. And a lot of the places where that stuff is being addressed is in survivorship programs. A couple of things that I thought about, just from our conversation that we could potentially do is if NCI designated cancer centers are excluding people with metastatic disease, could we go to NCI and advocate that as a part of giving money to these NCI designated cancer centers, then their programs need to be inclusive. And I think also in that Twitter chat that was discussed, there was discussion about the Commission on Cancer. And I think the Commission on Cancer had a requirement that their accredited hospitals did survivorship care plans for people when they concluded treatment. And they were really struggling to meet those requirements. So they were looking for ways to narrow the definition of who they needed to take care of, basically, who they needed to do these plans for. So you had to be 100% completed treatment. So if you completed treatment for early stage breast cancer, but you were still on, tamoxifen or an aromatase inhibitor, they wouldn't do a survivorship care plan for you because you were still in treatment. But really what they were trying to do is reduce the denominator because they were struggling to get the percentages that they should. So it was all about limiting that denominator, which means exclusion and not as opposed to being inclusive. They've really gotten away from that requirement. And now they're doing survivorship programs. But I think that there's an opportunity to talk to them about the need to make that inclusive. But then again, the other point is then how do you make sure that trickles down?
Yeah, they were checking a box instead of actually taking care of people. Exactly. And I realized at the beginning of this that we were remiss. You guys all know Shelley, but I know a lot of you on here, a lot of you don't know me. In my former pre-metastatic cancer life was a physician. I guess I'm still a physician. I just don't practice anymore. I was an OBGYN in solo private practice. I worked all through my early stage cancer diagnosis. I was back in my office seeing patients 2 weeks after a bilateral mastectomy. I still had my drains in. But when I was diagnosed with metastatic disease, I was on IV chemo and developed permanent neuropathy. And you don't want somebody catching babies or wielding a scalpel if they can't feel their fingers. So that was the first thing cancer stole from me, was my career. And just that someday it will steal my life. I use the hashtag not dead yet. I'm very sarcastic. I'm very snarky. There are people on this call like Stacy who can attest to that, Martha as well. So I just want to give you a little bit of background about me. So, hey, Stace. So I really understand this difficulty that Shelley mentioned in calling those of us with cancer patients. You know, I am trying because I took care of patients my entire career. So I'm really trying very hard, as are a lot of people, to use people first language. It's really, and I'm very active on Twitter, as many of you are, and we have that character limit. So it's really easy to, you know, to fall into that, you know, abbreviating patients as PTS. So I've come up with my abbreviation that I'm trying very hard to use. It's PWC, people with cancer. So again, remembering that we are people first, that we are not our cancer. The Living Beyond Breast Cancer organization had a conference over the weekend, and Dr. Don Dizon, who is amazing. You all need to follow him on Twitter at Dr. Don Dizon.
Oh, yeah.
He is amazing. You know, he said something about, you know, cancer doesn't define you. You are not your cancer. You have cancer. You aren't cancer. And I think that's something that's really important for all of us to remember. We are so much more than the cancer that we've been diagnosed with.
When I mentioned yesterday when I was talking about our podcast, I did an episode with Dr. Dizon. And when I was talking about having the blanket over my head, it was when I was interviewing him. He's wonderful. I love him, and his TikToks are so great with his dancing. But I love that. I love the way he talks about it too, that yeah, you have cancer, you're not defined by your cancer.
So have any of you been in a survivorship program? I'm just, I'm really interested. I know when I was early stage and theoretically finished for the couple of weeks before I got diagnosed metastatic, nobody ever talked about a survivorship plan, or, you know, it was like, oh yeah, you need to follow up with the oncologist. Nobody ever talked about, oh, you were on an anthracycline like adriamycin, and you may develop cardiac problems 5, 10, 15, 20 years down the road. So I'm really interested in hearing what other people's experiences were. I live in a small town. We don't even have an oncologist. So I wonder if people that were treated in bigger centers or in other places in the country have different experiences.
What do you mean by a survivorship program? Is that like something with your doctor or a group?
Well, the Commission on Cancer has mandated that places that provide cancer care are supposed to have a survivorship plan, that at the end of when someone has completed their treatment, that it's like, okay, you finished your treatment and now you had this kind of treatment which could cause heart problems later on. So you should follow up with a cardiologist in 5 years, things like that.
Yeah.
And it's supposed to be a written document that is given to the patient and ideally provided to the patient's primary care physician. I do not know a single person who's ever received that survivorship care plan.
Yeah, I haven't even heard of it.
Yeah, I haven't heard of it either. And I mean, my care is at Dana-Farber in Boston. So that's like a pretty, at least around here, well-known cancer center.
Yeah, it's a very well-known cancer center with some pretty amazing people, oncologists of all types. So I think that's really interesting. It doesn't seem like any of us have gotten a survivorship care plan or even really know about it.
Yeah. And I'll mention, I go to an NCI designated cancer center as well. So
yeah,
I've never heard of it. So
and I think a survivorship Shelley, correct me if I'm wrong, but is a survivorship program one of the things that an NCI designated comprehensive cancer center is supposed to have? I mean, there's certain things they're supposed to have.
I don't know what their requirements are for it. So that's something I need to find out. I think some, the thing is, there's not a lot of money in it and so they do it to provide good care to patients and for their reputation to some degree. I mean, I had somebody who works at a very esteemed cancer center tell me that it was a lost leader for them, but they do it so that their, breast cancer patients who've completed treatment can, recommend this renowned cancer center to their friends, because the money is in the treatment, not in survivorship care, because survivorship care is usually an office visit to discuss issues you may have. It's not procedures or chemotherapy, and that's where money is in cancer care, unfortunately. So
that's where money is across medicine. Money in medicine is in procedure, heavy specialties. Yeah.
Yes.
But Stacy, you put in the chat box there that you had to request a survivorship plan. Stacy, for those of you that don't know, is a very active, very well educated, very, very proactive advocate for herself and for others. So you requested one, and you mentioned that you kind of found it worthless. I'd really love to hear a little bit about your experience with this.
So I am treated at Kaiser, and I am not metastatic. I had early stage disease. I was diagnosed in 2013, and yeah, I would love to keep it that way. But I do a lot of advocacy in the metastatic community. When survivorship plans were recommended, I found it really, really interesting because I had never met anybody with one either. So I went back to my oncologist and said, what's this with a survivorship plan? She says, oh, we're going to start issuing them, but you won't actually get one because you completed treatment and kind of, got past that 3-month period, a couple of years ago. And I said, well, I would like one. And she says, okay, I'll put one in for you. And what it amounted to was a physical document. They printed it out on paper. It was not available to me through my portal. It was a treatment summary, which was valuable. And I think that everybody, should somehow have either a copy of their health records or, their treatment summary. And then it had recommendations, screening recommendations. Well, it was fascinating to me because I had ultimately I ended up with a bilateral mastectomy and bilateral reconstruction, and it was recommending for me that I have mammograms alternating with MRIs every 6 months. So it didn't even look at me as an individual. In it said, continue to take your hormone therapy if you have been prescribed that. So in no way, shape, or form was it actually personalized. The dietary recommendations were the same dietary recommendations you would get if you went to your doctor and said, how do I eat a healthy diet? They weren't necessarily, they definitely weren't cancer specific. And then it was really interesting because I think Kaiser was trying to build this out as a program. And so they called me and they said, they wanted to enroll me in this survivorship class. And I was thrilled. I was super excited. And the guy called and he said, well, how are you recovering from surgery? And I'm like, pretty good. And he goes, oh, great. You're not having any. I'm like, surgery was 3 years ago. So yeah, I'm recovering great. I get in the queue. I say, yes, yeah, it's been a while. I do want to go see what this clinic looks like. And it was all cognitive behavioral therapy. So what they were telling people is, okay, you've just been through this incredibly traumatic, trying, frustrating, terrifying experience. And, all of you in the room had kind of come out the other end. And now if you had any feelings of fear or anger or frustration, you should create a gratitude journal. You should just write down everything you're grateful for. And as Kelly knows me in person, it was very hard for me to be quiet when somebody said that. And so I wasn't quiet. So I was asked not to come back to the survivorship care class. But that did turn into a good turn of events. I did go all the way up the chain at Kaiser leadership, and we've created some things beyond that. But yeah, and Kelly, I don't know if she mentioned I joined late, but we were invited last year, thanks to Martha, to the mask conference.
No, we weren't invited. We invited ourselves.
Both. And there is a lot of talk. There was this push that people had to receive plans, and now there's this walking back to say, is that actually really valuable?
Again, and Martha can probably speak to this too, because we saw a tweet. We're all very active on Twitter. We saw this tweet about this survivorship conference, and Stacy, you probably have a better memory than I do. I don't remember what MASK stands for. And it was in San Francisco, which is near where Stacy and I live, very close to where Stacy lives, not, a few hours from me. And we're like, oh, this looks really cool. Like, where's the patients on these panels? And there were no people living with cancer on these panels. So we kind of made a Twitter stink about it. Martha was very involved with that. And so we kind of got invited to participate. But the bottom line really about these survivorship care plans were really that they were worthless. And I think one of the reasons they were worthless is because they were designed not with people that have had or are living with cancer. They were designed by some bureaucrats who decided that this was something they needed to do. Martha, please.
Yeah, I mean, when Stacy just said they're walking it back, walking back, believing these have value, I'm like, why would they weren't designed to have value, because like you just said, they didn't talk to the people who are impacted by it. So I did not actually know that, Stacy. So I find that offensive basically, because it's just, yeah, sorry, go ahead, Shelley.
So I just want to say something a little bit about the problem is that how they've been implemented is not what was originally intended.
Mm-hmm.
So they came out of the Lost in Transition report that the Institute of Medicine did in 2004, 2005. And that was basically looking at how people, when they completed treatment, were lost in transition because they were basically just told, go live your life, you're done. And the idea was that having a plan that had the treatment summary that then you can share with your primary care provider and any other providers who would need to know what kind of treatment you had. So and that you need to have a cardiologist if you had anthracyclines or things like that. It was never intended to be the kind of recommendations that you're talking about, Stacey. It was actually supposed to be, first of all, it was supposed to be about a discussion with the patient and then handing them the paper that summarized what was discussed. So it was about a transition, helping them make that transition to post-treatment care. And then it was supposed to be personalized, not just blanket recommendations. But that's not how it was implemented. So I think, yes, they're worthless, but they actually were designed with patients in mind, and they just weren't implemented that way because it was just, oh, we have to get this out. So if we're going to check the box that we gave Stacy her plan, we'll just print this thing out that really has nothing to do with her, as opposed to a plan that actually really was meaningful. But the other piece was that we also have advocated for those kinds of plans being provided to people at the beginning and updated throughout their treatment. And then actually it might be meaningful if you are somebody who completes treatment to then have this summary and recommendations going forward, but it's been this living plan throughout, as opposed to just a check the box exercise at the end. Now, Gina, I'm sorry, Gina, I just wanted to.
That's okay.
Yeah.
Stacey, I love your attitude. I love the fight, and I love it because that's how things change. Now, I might be naive, and maybe I was just lucky. My surgeons at Mass Eye and Ear, my radio oncologist is at University of Miami. They have me come in every 6 months, and we redo a plan. Take a CAT scan, take this, take that. They have actually walked me through without a plan. They have been there backing me. And they said, according to the government, and I have good insurance, they should have stopped. I should have stopped at 5 years. And they have gone over and above, and they have pushed me through. I've never been offered a survivorship. However, my background is for 35 years. I worked with a cancer organization, and I gave out grants to different groups. And maybe that exposure gave me a little background and information, but I've never been quiet. And Kelly and Stacy and Martha, good for you.
Thanks, Gina.
Well, I think the first step in advocacy is we have to be advocates for ourselves. And, the first time we ask our doctors a question, we're being an advocate for ourselves. Cute dog there, Doug.
Seriously, he's adorable, or she.
So what other things? I mean, it sounds again like most of us haven't had exposure. Stacy had to go after it. Martha put a really interesting thing in the chat box here, that since COVID, she's had all this contact with her hospital, like dietitian and mental health person, all these people calling. I'm like, damn. I mean, if I didn't have I have two oncologists, so a semi-local oncologist that I only have to drive 45 minutes each way on a good day with no tourists and no snow. And I have a big expert oncologist at an NCI designated center in San Francisco. And if I didn't have that San Francisco oncologist phone number, and I wasn't texting her about referring a patient to her, a person with metastatic disease to her, I wouldn't have heard from anybody throughout this pandemic. So I think it's really interesting, Martha, that you've had some outreach from your facility offering stuff to you.
Yeah, I know somebody who works there, and I was asking her about this, and she thinks that possibly it's, you know, because they've been losing money, basically. So they're trying to, you know, show purpose for people there. That's her speculation. I actually don't know the reason, and I haven't asked why is this being done, but if I were more newly diagnosed or was having some serious problem, it would be so appreciated. I hope they keep it up, basically.
Yeah. Now, this isn't necessarily on topic, but, hey, I have the mic, so I'm going to ask a question of you guys. How many of you have utilized telehealth services during this pandemic?
I have, yeah.
Okay. Almost everybody. I have a telehealth visit with our palliative care doctor tomorrow. I mentioned I don't really have pain, but I have some discomfort from bone metastases. So I'm having a telehealth with her tomorrow to get a renewed referral to physical therapy. So I'll see how that goes, and hopefully everyone's had good experiences with it. Now, kind of again, just segueing, since you've had this experience with telehealth now during COVID, is this something you would like to see continue after? Have that option to see your providers via telehealth after this is over?
For me, it came in the talk earlier. I don't remember which guy, it was one of the men, mentioned about you don't get the hand on your knee or a hug, and you don't get the actual physical checkup, but it's more convenient. But, I live about 2 miles from an NCI designated cancer center, and I still go to see my oncologist, but you have to wear a mask, do the temperature, you only go by yourself, all that jazz. But I totally miss the human contact. I love the telemedicine is great for, like I had a dermatologist appointment because I had some weird precancerous growth, but I could find oncopsychologist, my oncologist. I totally would rather see him in person. I don't know about you guys, but I miss the hugs and I miss just the in person.
I mean, I've found my doctors are more on time with telehealth appointments. Like, because they send you the message when like the doxy link is ready, so you're not like sitting in an office waiting around. So I've liked it, but I mean, I miss interacting with humans, like you said. Like, I work remote most of the time anyway. Pre-COVID, my team is all remote to me, so like I spend a lot of time on Zoom. Hence my multiple Zoom backgrounds. So now it's just like even more time on video calls.
I every once in a while it'd be nice, save me the trip. But I'm just so ingrained because, like I said, starting out at stage 4, and that first year, it's to me, you don't even think about survival. At least I didn't anything to do with survivorship. It was like just staying alive, basically. Because when I went, mine was so advanced. It was like, am I going to make it 6 months or whatever? Which I have. It's been 2.5 years. And maybe, I'm kind of looking at, the prognosis, you get the prognosis, a lot of people outlive it. So when I get to 5 years, I think survivorship might make a little more sense. But right now it's just constant treatment. It never stops. But since it's post like that first year, it seems like it's more management, even though I'm still doing treatment, as opposed to that first, when you get diagnosed and go through all that stuff. And I think that's why I kind of like the human touch, because I don't have that first year where you're always seeing somebody. I don't know. It was a mental that really helped me a lot, and you leave that as a survivor, and a lot of that care you got used to, at least mentally, you don't have it anymore. So I do have an onco-psychologist, and I do have a psychiatrist through the same place, and I get a lot of mental care, but it's just still a tough phase because, you know, first year I hate the word fight, but I mean, I'm so focused on living, getting, you know, staying alive, and now it's more just management, you know, but even though it's still keeping me alive, but I don't know.
Well, and I think, Doug, you just brought something up that I think is one of the reasons why this whole idea of survivorship came up. It's, you're in active treatment, you're seeing your oncologist very frequently, you're followed up for a while pretty frequently, and then all of a sudden it's like, okay, you're good.
Mm-hmm.
And that can be, yes, I know.
Another dog.
No, it can be so hard. It can be, it's like you're set adrift in the ocean with just like without even a life ring. And you're supposed to figure it out yourself. But something that Shelley said really, really struck me as well. And that's the idea that, you know, we should start this when we're diagnosed. I mean, I may have been a doctor. I'm not an oncologist. And when I was diagnosed with breast cancer, and, you know, had to go the treatments, and it was like, I had no clue what to do. I had no idea what to do for side effects. I live in a small town that didn't even have a cancer support group until a friend of mine and I started one after I was diagnosed with metastatic disease. So, I mean, like almost like cancer boot camp. We need cancer boot camp.
Yeah. It's not something you get trained on throughout life. It just happens, and then boom, what do I do?
Yeah. Stacy always makes good points, that, you know, obviously our experiences with telehealth may vary, but the reason for the appointment and the goal of the appointment are two things to consider. For me, again, I have an appointment with my local-ish oncologist next week, and I'm going, the freaking tourists are here. Do I really want to drive around the lake? So I'm going to convert that appointment to a telehealth visit. But I have an appointment with my San Francisco oncologist in August, and I'm like, I so need to get out of Lake Tahoe that I don't care if I have to drive 4 hours down and drive 4 hours back the same day. I'm going to go see her in person.
Can I ask you a question?
Yes.
Louise Keller.
Yes, I just got a message from Louise. Yes, I know Louise.
And I've been supporting your organization.
Oh, thank you. Thank you.
Okay, I'm sorry.
That is so funny. Small world. So I'm on the board of Metavivor, which raises money for metastatic breast cancer research. Louise lives here as well. And we do a fundraiser to raise money for research through Metavivor called Music Through Metavivor. So thank you, Gina, for that support in the past. I just got an email from Louise while I was on this call. That's very funny. So when I talk to her, I'll mention that I met you.
Okay.
One thing I've been thinking about, just listening to you all and thinking about some of the other conversations that I've heard about this recently, is I do think all of this is really siloed. And, you know, it's basic, like Doug, you're saying you don't feel like you're ready for survivorship care, but really, what if we just called it supportive care? I mean, I know there's still, you know, the palliative care experts who some of them still cling to that word. Others acknowledge that we need to move it. But I did hear a talk from Patty Gans from UCLA a few years ago at the first palliative care and oncology symposium that ASCO did. And it was called Survivorship Care is Palliative Care, because it is really about dealing with all of the other effects of the treatment on your life and of the cancer on your life. So it's not just about the pain, but about like helping you live well. I mean, maybe, but palliative care turns a lot of people off because it's equated with hospice care. But maybe if we just called it supportive care, and then it's supportive care for anyone with a cancer diagnosis, regardless of where you are in that diagnosis, whether you were just diagnosed or whether you completed treatment or whether you will ever finish treatment.
And there's such a diversity among what's offered. This was a huge topic last year of people that wanted to be in their cancer center's palliative care program, because it offered a whole lot of stuff. It offered, some integrative supportive services like acupuncture. It had massage, but they were told they weren't sick enough. And I think a lot of this all boils down to money. There's not the money to run programs the way they're designed to be run. ASCO states that every single solitary person diagnosed with advanced or metastatic cancers should be offered palliative care services, supportive care services, and they should be offered it upon diagnosis. But there is not the money. Again, it's not a procedure specialty. So the reimbursement is not as good. There are a lot of us that don't. I'm shocked that we have a palliative care doctor in my small town. I mean, orthopedic surgeons are gods here. We actually call them the ortho gods. They just got a new $20 million building, but we don't have an oncologist. We cannot get chemotherapy in our town. You have to drive at least 40 minutes to an hour away to get chemotherapy. But we have a palliative care doc. So I feel very lucky about that. Where I know people that are at larger centers that have advanced and metastatic cancers that are not able to access palliative care services because they're just not sick enough. So that's a problem as well.
Yeah, and I was talking with Dr. Smith yesterday before the main session, and he was, he was talking about using neuromodulation to help with pain and address peripheral neuropathy, and that they're having a lot of success with it, and that he's got a paper that he's going to be publishing soon. He said, but there's no money in it, so people aren't going to do it. And I mean, because it can't be done by telehealth. He said it's basically like using EKG sensors. So you've got to actually put them on. I don't understand. He was telling me this, and I'm like, I knew we weren't going to have time to get to it in the conversation yesterday. I'm like, okay, I think we're going to have to do a podcast on this, and you're going to have to explain this further. But again, it's something that can really help somebody's quality of life, but there's not money in it. So it's going to be hard to access. Also, we had Dr. Michael Stubblefield, who does cancer rehabilitation, spoke at a meeting we had earlier this year. And, it's just, there's so much benefit to people with cancer of having this rehabilitation, and it can be during treatment. It's not just for a post-treatment, but again, it's reimbursed, but oncologists aren't referring people to it. So it's not very widespread, but it can be a huge benefit to help deal with quality of life issues so you can live better, regardless of where you are in your cancer treatment.
I think this is where advocates can play a huge role. And I've heard the word silo mentioned a few times. And I think it's the bane of all of our existences. And if we look at centers and we expect them to be the end all be all and treat our cancer in the best possible way and treat our mental health and help us figure out goals of care beyond cancer treatment, I think we're going to be feeling like we're swimming upstream for a very, very long time. And I think there's this explosion for better or for worse of nonprofits, of fairly well-funded smaller organizations that want to do one thing and they want to do it really, really well. I'm sure that most of you are treated at institutions that have patient family advisory councils or something like that. And Kelly's like, oh, hell no, I'm not. but if you are at an NCI a designated center, they typically have them. One of the things that I would encourage you to do, whether or not you have a family patient advisory council, understand what's in your area. And if there's truly a gap, if there's nobody that's providing some of this supportive care, and I love that term, let's figure out how to build something in your area. And if there is, people need to get over their egos in the institution. Kaiser does a lot very, very well, and they do support really, really crappy. And I've gone on record saying that, so I'm not revealing anything. And so we need to work with the community and the community organizations that can do not only support really well, but personalize it, right? We have a huge Latinx population here, and we don't have to at Kaiser put everything into the support groups that are in the hospital. We can actually go to Latinas Contra Cancer and say, hey, these are the people who are coming into us. How do we get them to you? What's the best way to get them to you. And they already know how to kind of do things appropriately from a language standpoint, from a cultural standpoint. They're the best group to help with screening. I mean, Kaiser can preach all day about how you need to get screened, but going to the community leaders and having those people talk with the community seems to work better. So
that's a great point, that we don't have to necessarily do things within our center. Shelley, if you can, I just tried to look for it and I couldn't find it. If you could maybe post in the chat the link to Tom Smith's article that was in the Atlantic.
Yep. So his was in the New England Journal. And
New England Journal. No wonder I couldn't find it. I was looking for the
Yeah.
wrong. I like it in the wrong place.
So I can do it, but I will say that it is something you have to have a subscription for.
I was able to read it without a subscription.
Okay.
And I think you can sign up for a free membership, whatever, in the New England Journal, and you can access a certain number of articles a month. Because I know I was able to read it without having to pony up any money, which is another thing that drives us people with cancer crazy, are paywalls for journals that are talking about us.
Right. So there is even if you can't get to the article, there's an interview with him that I think it's about 20 minutes that you can listen to. And then I can't post it, but if you email me, I'll email back to you.
Will you put your email up again?
My email, I put it there.
You did. It's in the chat.
At Cancer.
Where do you go to chat?
So if you look on the bottom of your screen, or on an iPad, it might be over on the left-hand side. There should be a little box that looks like the little message thought bubble thing. That's chat, and you can see the chat there.
Thank you.
You're welcome.
He was pretty awesome. I mean, I know him and knew he would be awesome, but I didn't even realize he was going to be quite as forthcoming about some of the issues. But then when you think about he's a medical oncologist and a palliative care expert, and he didn't know all these things because he was a breast oncologist, or he is a breast oncologist. So he didn't know about all these side effects of treatment, and he learned it from other patients, not from his doctor. I mean, that's
right. That's what we patients do.
Yeah.
He has, for those of you that don't know, he has metastatic, right? Prostate cancer.
Yeah.
Yeah. And he did an awesome session yesterday. And these sessions, because there's a lot of concurrent sessions, these are all going to be available, correct? Shelley, can you tell us how to access the things that we weren't able to watch in real time?
I believe they will be on the same place where you registered. That site the agenda link should be updated with the actual with the recording after the fact.
The link was in the email.
It doesn't happen immediately. It takes a little time too, but and I haven't looked to see if yesterday's are up yet, but hopefully they will be.
Yeah. Yes, they are.
Okay, good.
Oh, thanks, Doug. So our time is up. I really want to thank everybody. I mean, Shelley probably should be thanking anybody, but I'm kind of a pushy, bossy bitch. So I want to thank you all. Really want to thank you all for joining us today, talking about survivorship and words and what matters, words matter, and how to make things better for all of us.
Thank you, Kelly, for facilitating the conversation. And thanks to all of you for joining. And I love seeing your backgrounds and seeing your dogs. And so I appreciate you showing your faces and sharing your experiences with us.
All right.
I didn't even know about this till yesterday. So
I'm glad you joined. That's great.
Glad
and so we'll be back again next Monday with round 2. Yeah. So we'll see you then. Thank you.
Okay.
Thank you, everybody. Everybody have a great day. Stay safe.